Buenos dias. With a show of hands, who likes to shop for a TV? Yeah, good, exciting. Who likes to pick a restaurant for a special event? Oh, lots. Great. It's fun, right? Who likes to think about their personal finances? Nobody. Well, it seems that Americans spend more time buying a TV and choosing a restaurant than they do planning for retirement. However, we know financial planning is important, right? When I was 18 and waitressing to pay for university, well, I wasn't making a lot of money. I wanted to spend it well. Since I'm not a financial planner, I talked to one. I needed to decide how much to spend on groceries. I ate a lot of noodles, to be honest. Rent, well, I cut costs by having roommates. Transport, I biked as much as I could. And tuition, very important, good return on investment, as we all know. Then savings and investment. My financial planner showed me modeled projections, and we decided how much to put away from each paycheck on investment and in savings. And we reassessed over time. This meant saying no to many tempting purchases and expenses, like a TV. That didn't happen back then. But I was happy knowing that I had the privilege to continue studying, and I was being financially smart. If I wanted to go to a restaurant, I could pick up an extra shift. But first, I had to pay my rent and my tuition, the core expenses. We all know that saving and investing now, or at the time, will mean bigger returns later. But it can be hard to say no to many good uses of limited resources and to make the best choices. So, how does personal financial planning relate to sustainably financing the HIV response? You thought you were at the wrong talk. In both cases, planning for strategic investment must be a priority. We, country governments, may need to leverage extra resources. It's not only about saying yes to the most impactful approaches, but understanding which good things we have to say no to so we can prioritize for bigger impact. As we know, tremendous progress has been made, but we're not tracking to targets. There has been great reductions in infections and deaths since 2010, but we must invest better to prevent more infections and to save more lives. Here is the HIV resources and gaps since 2010. In the blue bar, this is the domestic and public and private spending. In the yellow, this is the United States donations. In the orange, Global Fund, and in the pink, Other International. This is from the UNAIDS Global AIDS Update that just got released. However, there's a $7 billion gap in last year. So what are we going to do about that? Another way to look at it is HIV resources and resource needs per person living with HIV. This is shown in the blue bar. This includes both prevention and care. And then we divide it by the number of people living with HIV and the population. So you can see in 2010, it's about $600 per person living with HIV, down from 2017. However, towards the 2020 goals, here are the resource needs per person living with HIV. You can see the gap. Next, comparing that to the trend in incidence, which is declining. However, this is our target, and deaths, which are also declining, and this is our target. So again, we must invest better to prevent more infections and to save more lives. Stover and colleagues showed that if the funding gap is filled and HIV coverage targets are met, then the 90% reduction targets could be met by 2030, as you can see here with the fast-track approach. There's a 20% cut expected from a major donor as of this year. We wanted to model to see what would happen if that occurred and was maintained till 2020. And we projected that over that period, there could be 700,000 more infections, or 3% more. That also includes 100,000 or 0.5% more deaths. We also wanted to see What would happen if by 2030 all the donor funding was removed? That shoots up to 2 million more infections and 500,000 more deaths. We all know if we don't invest better now, more people will become infected. It will cost more lives. It will cost more in the long run. Avenir Health and the UNAIDS group have shown the consequence of a 5-year delay in achieving the 1990 targets. So if these targets were achieved by 2025, they project 2 million more infections and 1 million more HIV-related deaths. So I ask you, are we okay with potentially 2 million more infections and 1 million more deaths? Is anyone in this room okay with that? So how can we avoid this? A study by Hackenstadt and colleagues wanted to look at the potential for additional government spending. Governments are being encouraged to leverage more domestic finances and to take more responsibility for their response. And this would lead to more sustainable response, of course. So they looked at many countries, but this figure shows the 15 countries that received the most donor funding in 2016. You can see in the peach or the pink bars, this is the domestic spending. In the blue section is the development assistance for health spending. In the green is what they projected or modeled for potential additional government spending, the potential. Then on the right-hand side is on a scale of about up to 100% for the domestic plus the development assistance, and then the green bar is overlaid to show a potential for additional government spending. So you want to see the balance between how much more they could leverage and how much they're getting in development assistance. And you can look through the countries to see how that balance lines up. Again, this is for benchmarking only. Of course, there are limitations to sourcing more domestic funds. But the question I ask you is, should donor resources be reallocated between countries? And if so, how? Who should get more? Who should get less? Our group, a country government and a consortium together with the World Bank, looked at optimizing or better HIV spending in Sudan as one example. The bar on the left-hand side is in 2013 how they actually spent their resources. As you can see, the bars in blue are the key population prevention, in yellow are the general population prevention, in green is treatment, and the gray are those overhead costs, those fixed costs, the management, etc. The center bar shows you, after running our modeled optimization, our recommendations were to increase treatment, increase spending on treatment, prioritize prevention for key populations, as Sudan is a low-level concentrated HIV epidemic, and if possible, to reduce the management costs. However, we don't take these into consideration, because how do you measure hiring one more healthcare worker on the actual number of people you save or infections averted? It's hard to say, so we just suggest reducing management costs. So increasing ART up 6% and key population prevention from 7 to 29%. Those were the recommendations we gave to the country. What actually happened? They got less funding. However, they uptook some of the recommendations and they spent more on treatment and they spent definitely more on key population prevention. And what we forecasted could happen by 2030 is that they can invert more infections and more deaths, 33% more infections and over 20% more deaths. So this is one step, but we could find even more efficiencies if we optimize subnationally and across service delivery modalities. That would be the next step. So that's Sudan. Now we thought, what if we looked at the global scale? So we worked in almost 50 countries, but here we took 44 countries with some subnational representation that captures 80% of the global estimated people living with HIV. It's a very busy slide, but the thing that I want you to look at is on the left is how countries were actually allocating their resources, and on the right, the optimized reallocation or the recommendations for that. You can see in the green, that's ART or the treatment. You can see a lot of increases in the actual recommendations for increasing treatment. But overall, to minimize HIV infections globally by 2030, the recommendation was to scale up treatment from 44% to over 50%, and to prioritize key population prevention programs, as well as harm reduction services, needle syringe programs, and OST. Now again, if something gets prioritized or scaled up, or we spend money on something, then what has to lose out? It's not to say that anything we recommend deprioritizing is not important, but at this budget level, something unfortunately has to give, or things have to become more cost-effective in order for us to prioritize them. And what we saw was the general population preventions, particularly in concentrated epidemic settings, were getting deprioritized. After optimizing the global spending, here's where we projected as better outcomes. From 2015 to 2030, we projected that 7 million more HIV infections could be averted if the budget's amounts were better spent. Again, that's at the same budget amount. And the next thing was answering my previous question. What if the donor funding could actually be shifted between countries based on where it's going to get the most impact? So again, this is a hypothetical, but we actually found that 1.9 million more infections, and in total 30% more overall, could be averted if international funds were to be redistributed optimally between countries. Perhaps that would be of interest to our major donor partners. The next thing, and like we did in the global model, is not to necessarily just look at the national level or at the global level, but we want to look subnationally. We want to drill down. This is one example of such a study that was done in Malawi. In the map is a representation of the HIV prevalence, and then by district, on again the left is the actual spending, and on the right is what we recommend for optimized spending. You can actually see, though, that the levels shift. That's all I want you to take away from this. It might be very difficult, but in order to get the maximum impact, we may need to redistribute money within the country and distribute it differently. We also looked at the modalities for testing, and so you can see here, at least nationally, a change in the distribution of modalities. Some modalities may show more cost effectiveness. Here's a quote from Paul Farmer. "We've met the enemy and he is us. We're the ones asking for the resources and then misdirecting them. More people are dying because of our bad spending choices. But by making better choices, we can save more lives and avert more infections." So how can we do better? We want to target the right interventions, fund the most cost-effective, highest impact interventions. These include treatment, key population prevention, circumcision, especially front-loading for longer-term benefit, as we've seen pre-exposure prophylaxis were indicated. Like I said, we want to prioritize targeting of differentiated prevention and care services across the cascade, and everyone wants to look to cut management and overhead costs while still maintaining an effective program. So something we have to say yes to, and there are things that we're going to have to say no to. We want to target the right people, those most affected, most vulnerable, in the right places, like we did the geospatial analysis, to where there will be the most impact. And the right strategy. There are many things in the right strategy, and it depends on the context. But strategic buying, reducing the procurement cost, is a win-win, in my opinion. Mitigating out-of-pocket fees for services so people can access them. Joint service delivery, like we've seen from Dr. Martinez. That's important and a big consideration. And integrating the HIV response within universal health coverage. So what must get deprioritized? Again, saying yes to what is cost-effective, that's relatively easy to agree on. Saying no to what's not as cost-effective, this can be contentious. Everyone thinks their program is important, and it is, but if it has to be defunded for the greater good with regards to cost-effectiveness, then there will be people not reached for services. But this is a limitation of limited budget. The challenge is to say no to what might be an excellent program and doing good work for people in need, but in the big picture of a country's epidemic or local epidemic, it's seeing which programs will do the best and make the tough calls to say no. However, there may be reasons for less than optimal spending. Funders may provide funds for causes that concern them most, such as HIV programs targeting adolescent young girls and young women, orphans and vulnerable children. So if they thought that funds might be redistributed if they were meant to be reallocated towards another program, that money might be withdrawn. So there are certain constraints, and we can actually include those in the model. They're ethical constraints. We don't take people off treatment, etc. So we want to use evidence to inform the best spending choices within the constraints. Here's what I want to show you about return for investment. This was a study done by the Copenhagen Consensus Center. They looked at all different areas, but I'm here just showing you the area of health. They picked certain metrics, and 2 of these metrics are directly related to HIV. So more male circumcision against HIV, and doubling HIV medication for the sickest. And you can see, for every dollar spent, this would be the return on investment for the doubling of the medication for the sickest, and this would be the return on investment for more male circumcision against HIV. Just something to think about. Forsyth and colleagues recently came out with a look at ART over the last 20 years, and they showed for every $1 spent on ART, $3.50 in benefits would be accrued globally. So like I said, there is return on investment, and we can see that, and we can use that in our planning and in our advocacy. So a quote from Gunilla Carlson is, "We urgently need increased political leadership to end AIDS." I couldn't agree more. This starts with investing adequately and smartly, and by looking at what's making some countries so successful. So let's learn from some success stories. These are just a few. Like I showed you, Sudan shifted funds from the general population to HIV treatment, and we estimated that we could save an extra 14,000 lives by 2030. Moldova, they coordinated institutions and cut management costs by 23%. We were actually working with them last week, this group, and we estimated that 11% more people could receive life-saving treatment based on these savings. I just heard yesterday, and I wanted to highlight this, that South Africa negotiated a 13% lower ARV cost than the 2017 global pricing agreement. So for the 2019-2020 period, the actual drugs were 68% lower than the 2011-2012 period. So in this case, over this time, 4 times more adults, 4.5 million, could receive treatment compared to 2011, 1.3 million people. So again, back to my personal financing planning story. With limited resources, we must cut costs on things, again, like rent, transport, but we must pay the tuition for the greater good and the return on investment. We must save, we must invest better to best reach our goals. My take-home messages: to save more lives and prevent more HIV infections, we must make evidence-informed best spending choices within our constraints. We must make the hard decisions and say no to less cost-effective HIV interventions. And I wanted to thank everyone who contributed, and gracias por la invitación.